what are your recommendations, Dr. Steves, for physicians in the community to optimize the success of these treatments?
Right. And I think the simplest answer to this is just following the literature. We've said it many times, we need this literature to mature. We need to see this is a long-term chronic illness we expect when a CLL patient walks into our doors, we expect them to have years, maybe even a few decades of survival, not just, just trying to control the disease and for a few months and see what happens. And I think the data will tell us more as we move along with that. I think about long-term MRD response rates, what they may mean, the efficacy of long-term drug-free intervals, and as we mentioned, the re-challenging versus switching to a new agent, what that's going to look like. We're going to have data on that, because CLL, nature of the disease, it probably will come back. To think that we will cure the disease in most patients is pretty unlikely. These chronic diseases generally don't, but so we need to figure out what we're going to do with these patients if and likely when the disease does return, and how many months or years that's going to take. Additionally, I would urge physicians to use all their resources, whether it's in-house pharmacists in the clinic, nursing staff, PAs, NPs, pharmacists in the specialty and community setting, just all the resources at their disposal to provide education to the patients. As a pharmacist in the specialty setting, nothing makes us happier than when a patient answers the phone and they say, I already had a teaching session at the doctor's office, but why don't I hear it one more time from you? And these are the patients I have the most confidence in are going to be the most adherent to therapy. And again, we'll do the best long-term on the therapy because of that adherence, because they crave the education and because they're seeking it out. But it's because it started in the doctor's office with, these are the resources we're going to give you to help you with this therapy. Because even if its side effects are pretty tolerable in most cases, it's still a complicated regimen usually, and there's a lot of issues that go along with it. So what about you? Same question, optimizing therapy for the doctors and how they should move forwards.
No, I agree with everything you said. I think from a education perspective, I think something that can be really helpful is just recapping on, like you said, on education, really using those open-ended questions that we learn about in school that sometimes gets missed in the shuffle, that can be really enlightening to help physicians understand, what some of the challenges are for patients, that might be assumed that patients are taking the drug and understand it, and maybe patients are too nervous to ask questions. So I think that that can be really helpful, just to kind of use open-ended teach-back questions initially, but also at follow-up, just to make sure the patient really comprehended and really retained it, because there's so much information. And I definitely agree with what you said in terms of the evolving literature and also using different colleagues for help. I think that's also a great point. So before we conclude today, I'd like to get any final thoughts that you have, Dr. Steves.
Well, I'd like to thank you, Dr. Duffy, and thank you to Pharmacy Times for allowing us to have this discussion today. I think I urge all pharmacists working in CLL or any disease to continue to follow the literature, keep track of the NCCN guidelines, which seem to be updated all the time. Every time you click on them, there's a new update or a new category, something like that, of the disease. And as this literature flows in, I think the question, and I learned this, back in my rotations, back in my education, we always ask ourselves, how will this change my practice? Because I can tell you the percentages, A versus B had this percentage versus this percentage, but, we have to weigh in all the factors of, did it increase toxicity? How is it going to change what I do and what I recommend and what I think is most appropriate for the best course of action for our patients? So we do have the luxury of multiple agents in this disease, which is a very good thing, but it creates the problem of deciding and dealing with which is the best for each patient. So medicine, we've all heard stated, can be as much or more of an art than a science sometimes. So it's kind of being creative and deciding which is the best option for every patient. But thank you again. Thank you for helping with this, and thank you everybody for watching the discussion today.
Yeah, I agree with your thoughts. I think I would also add that I would say don't be afraid as pharmacists to clarify questions, and oncology can be daunting for sure. So know that these therapies are not going anywhere, and so some of the resources that we pointed out already on the HOPA website, hoparx.org, and oralchemoedsheets.com are great resources for education. And honestly, it takes so many different pharmacists within the team, but other healthcare practitioners as well, to make sure that things don't get missed. So know that you're important in the whole treatment algorithm and treatment landscape for patients. And I think you should feel empowered to feel like you can help. I also think it's important to reflect and think about what are our strengths as pharmacists, because you're probably assuming correctly that we can always help with some of the things that we mentioned today in terms of access and adherence and interaction. So go with your gut and know that that is helpful, and more eyes on the patient is always a good thing. So I wanted to thank you as well, Dr. Steve, and to our viewing audience today, we hope you found this Directions in Oncology Pharmacy Insights discussion to be rich and informative. We hope you have a great day.